Yeah, thank you, Amanda. And welcome everyone to this day three. I'll be presenting Bridging the Digital Divide, promoting digital literacy and sharing knowledge translation content for maternal and child health in Nigeria. My name is Charles Chibisi, and I'm a PhD candidate at the Global Health and Infectious Disease Control Institute, Nasarawa State University, KEFI in Nigeria. I'm also the founder and the chief innovator of Familia Solutions. It's a digital app that helps women of reproductive age as well as children under 5 to optimize health access. So I'm a Black African with a short hair, wearing white in a blue flowered shirt, white background, blue flower shirt, a male, an African male in his early 40s. So basically, we'll just swing into this presentation. I want us to look at the core issues that has to do with Nigeria, as well as things that can also be adjoining to the other low and mid-income countries. Nigeria faces high maternal and child women in Nigeria. Also, largely most women in Nigeria lack access to reliable health information because there are infodemic a lot of information coming from different untrusted sources. There's also barriers that to them accessing this health information. One, given to their low digital literacy, misinformation, and exclusion. So exclusion could be in the form of low access to internet, low access to internet enabled phones, as well as low access to network to even access this information digitally. So and all those things were born as a result of poor infrastructure. So every day, preventable deaths occur due to lack of trusted knowledge. People don't get the right knowledge. People do kind of myth and makes people to Nigeria is 3 million persons, and when you look at the annual birth rate, our annual birth rate is over 7 million. The mortality maternal mortality rate is over 512, meaning that in every 100,000 women that give birth, 512 is likely to die. The fertility rate in Nigeria is about 4.8. And looking at the ANC coverage, the ANC coverage is also looking just a little bit average, 52%. Then if you look at the percentage of global maternal deaths for Nigeria, Nigeria is contributing 19% to the global maternal deaths. Then when you look at the indices around cervical cancer screening, Nigeria is 9%, which is very poor. Then looking at child mortality ratio, we have 132 child mortality rate, meaning that at in a given 1,000 births, that's about 132 children will die even before their first month. Immunization coverage, our immunization coverage is recorded at 42%, which is not even at average. So all those things are have the indices that accumulate to predisposing the Nigerian woman and the children, our children below 5, not accessing care and even dying from preventable diseases or vaccine preventable diseases. So millions of women in Nigeria still lack access to reliable health information, and this report was what spurred me into doing this, taking this dive in seeing how I can look at literature, look at what has been implemented across the regions, and come out with some solutions that will now reposition the women to take in charge of their lives. Then, why knowledge translation matters? So here, of course, we know that a lot of research has been done over time, and what we are doing here is to see how all this pocket of research will be turned into evidence that can now help improve health outcomes across board. So another translation connects the research to real practice. Then those real practices will now improve health to empower the women and their families. For maternal and child health, knowledge translation ensures that life-saving information reaches those who need those information most, especially for maternal, newborn, and child health outcomes. In Nigeria, like I said, the challenges are enormous, but we will focus on the key challenges that kind of predispose women and children to dying of preventable diseases. So when we talk about low digital literacy, especially among women in rural areas, so you notice that a lot of women at the rural areas, because of access, they don't have access to current and correct information. So most times they rely on what they hear, what people say. People can go, somebody can listen even to radio and comes to translate what is not true. And what happens here is that we live more of communal life. So once a respected community member kind of peddles false information, so it goes like a wildfire. So those are the issues kind of limit these women from accessing care. So there are many platforms that exclude low literate users. From what has been done, you see there are some interventions that they focus on digital intervention. They focus on the internet solutions. Majority of these households do not have internet-enabled phone. In fact, research have shown that 87% of the households have access to mobile phones, but the internet penetration in Nigeria is still below 40%. It's around 31, 32%. So any solution that is focused on internet, you've from the beginning, you've already excluded a chunk of women who are based at the rural settings. So again, like I said, misinformation spread quickly online. Like, there are a lot of people, those charms within those, locations that even manage to have access to internet, they can read those information and misinterpret them. And most of these women that don't have access to these modern facilities rely on them to kind of provide those kind of information. Then again, there are this issue of language barrier. In Nigeria, when we hear that we have 3 major ethnic groups, that is on paper. We have a lot of ethnic groups in Nigeria, and we have well over 500 languages. So no matter how you kind of program, you find out that some pocket of women within those rural areas will not be able to access those information, especially when you centralize them to say you are providing this information in English, Hausa, and Yoruba, or perhaps Igbo, and you're not doing, the dialects. So you've already excluded, this group of women, and children from accessing care. Then the Familia solution. This is a platform that I developed in terms with the mind of understanding all these gaps. It's a hybrid digital health platform deployed in both basic and feature phones. So whether you have an internet-enabled phone or you have just a basic phone, you'll be able to have access to this platform. So how it works is that for those that have internet phone, they can log on to the website www.familiasolutions.org and have access and register and have access to the platform. For those that just have normal basic phone that is just for them to answer call, they will call a short code 5432. So once they call that 5432 when it was live, they will gain access to the platform that welcome to Familia Solution. If you're a pregnant woman, press 1. If you have children between 0 to 5, press 2. If you want to meet a doctor, press 3. Those kind of formats. Then it helps them also. And one of the key features of this platform is that it speaks their language. So it helps them, to setting the language they want the system to, interact with them with. So for English, press 1. For English, press 5. So they are comfortable, accessing information or the platform in the language that is most suitable for them. So, and the system was, co-designed with the women. So I went to the communities, asked them what could be the ideal, a platform for them, a platform that will ensure that everybody is, is participating. And those feedback we are used to develop this platform. Now, this is talking about the user design. So, like I said, it's a hybrid system, works with or without internet. It provides content in the local languages that people are comfortable accessing information or content with. Of course, the women were at the core of this design. So we had an extensive discussion, and that makes a good platform for them to participate, and all those we are put into consideration while this app we are developed. Then so this is just talking about the stages, how the approaches that the development of this process went to. So it was participatory, it was co-designed with the women, the caregivers, and the health workers. Of course, it was the health workers that that kind of link especially the pregnant women that participated in the process of the development of the Then we looked at some empirical data to gain insights. From the fieldwork. Then we'll look at also other peer review articles, people that have implemented digital solutions, across the country. Then use some of the quotes that people will say, oh, this is what we would have wanted to see in an ideal situation. So all those we are put into consideration while we are developing that app. So one other key feature of the Familia solution is the AI. So the AI for maternal reproductive assistance. So this AI, while this was live, you can call into the AI, ask some questions. the AI will give you, provided those issues are not complicated issues, you get some insight on, on what to do. And also the AI does is that the platform nudges, it nudges the, the users on some of, especially for pregnant women, on some of the daily routines they're supposed to do, as well as even for the vaccination of the children. So it helps you to remember that next month by this particular date you're supposed to immunize your child, so you will not be able to forget. Same way for their hospital visitation. So the system automatically calls the person 24 hours before his appointment at the facility. So the person gets a call. Oh, remember, you have an appointment with the doctor by 10 a.m. tomorrow in the morning. Remember to go with your hospital card. 7 hours to the time of the appointment. The system also reminds you via call and send you an interactive voice response, IVR. So it's not just send call. They also send something that you can even play on playback mode. So we play down on SMSs because research have also shown that people that even speak particular languages find it difficult to read text messages in those languages. Like we've even seen some women, they speak Hausa, but they cannot read SMS in Hausa language. But once you hear the Hausa language, if you are an Hausa speaker, you'll be able to connect with that language, and it's easy for you to navigate. Then these are the dashboards while we are doing our trial on the trial phase. This is the interaction that we had. 56 total of 56 hospitals we are participated in this process, and you could see the interaction between the percent vaccination rate records. You could see from the platform the improvements that the system has brought into achieving better health outcomes. So these are also some other indices, like the system was able to track ANC visit, beds, records, vaccination coverage, facility bed. In fact, because a report showed that facility beds were even low. So from the small pilot we did, we could see that we recorded 12.3% increase over the last period. Of course, one of the challenges that we have in Nigeria is that data, data quality, disjointed data. You go to facilities, you can find the data for 2021, you will not find for 2022, you find for 2023, you will not find for, inconsistent in the data. But from the point that we were able to pilot this, we were able to consistently look at the improvement of these indices. Now, impact so far, we were able to record 4.5% increase from ANC coverage. So ANC coverage here is looking at women that attended at least minimum of 4 visits while they were, from conception to delivery. So vaccination coverage also, we recorded 4%, over 4% increase. For facility beds, 12.3%. Then there's also issue of their reduced misinformation through verified content. So we're able to give them consistent and correct information that they get from the platform. In addressing misinformation, AI-powered, we use these AI systems to power moderation and fact-checking information. So once they get information, we're able to fact-check those information and give them the correct information. Then we simplified this health content in their languages that they understand. We train the users to identify credible sources on where you can source for information, especially when it has to do with health. We build their resilience against false health claims. Those things that they say that vaccines are made to keep people impotent and all that. So we kind of play down, let them understand that some of those things are just rumors. So the system have been able to work both offline and online and offline, and we've been able to secure approvals for the full-fledged research now across the country. So I'll be deploying this tool in the 6 regions, 6 geopolitical regions, 1 state per geopolitical zone in Nigeria, just to ensure that we have a wider coverage that we can now generalize and say, yes, this platform is something that we can work on. So basically, this is geographical engagement. So here, unlike other tools, Familia solutions combines knowledge translation and digital literacy, worked both offline and online, and uses AI personalization to kind of understand the engagement with individuals and give them the kind of response that are personalized. So it's not like generic responses, but that these are personalized, individualized, responses. Then it provides real-time analytics, both for the health facility, the users, the staff, and also the project managers. So scalability, we're looking at to scale this, even beyond the maternal and child healthcare space, and look at non-communicable diseases, look at immunization, nutrition, as well as integrating it generally in health systems. And we are hoping to partner with government, NGOs, and donors. And our vision is to see, to having Familia solution to becoming a global model for inclusive digital health. So, so this is just calling out for partners and collaboration, to join us amplify this impact. Because with the little we've done, we can see the changes, and if this is done in a large scale, we are sure that we are going to change the narrative and the women, kind of reduce the number of women, dying giving birth. Of course, knowing that no woman should even die, giving life. So that's our goal, to stop any woman dying from, giving life. So this is how our intervention aligns with the conference, sharing KT content online and offline, promoting digital literacy, using AI to strengthen knowledge translation, involving marginalized users, especially those women at the hard-to-reach areas where they don't have internet, they just have basic phone, not internet phones. So to be able to also participate and feel belong. So thank you for listening. This is our contact. Should you want to know more, you can reach out, and we can forge the future ahead and save more women from dying. Over.
Thank you, Charles.
So I'll pause here. Yeah. So I'll pause here for questions, and I'll be glad to respond.
So we do have a few questions. So I'm going to ask mine first. So I am curious. So in your slides earlier, you mentioned that, the spread of misinformation on social media. And so I'm curious, in Nigeria, what are some of the popular social media platforms that people use?
Okay, so it depends on the location. So, but the most popular you can think of is WhatsApp and Facebook. Even with smaller phones, they have access to Facebook, and largely, large number of those smaller phones have access to WhatsApp. So you see a lot of messages going through WhatsApp. In fact, I did some mini trials. I just sent in a message, and a very, a specific message. I sent it out to a particular group, and I was surprised to receive it from somewhere I didn't know. It went off, came back, but because I did some marking on that particular message to make sure that was my message, and I wanted to see how long it would take for it to get back to me, or even whether it will even get back to me. And I was shocked. I was over 700 kilometers away from where I sent that message, and I received that message in another location in less than 3 days. So you can see the power of that, that network. So if anything is sent, a wrong message is sent, it goes like a wildfire to kind of, help people to get. So I don't know whether, are there any other questions on the chat?
We do. So Sean says, I appreciate this bridging the digital divide and increasing access to trusted information and healthcare in their language. I lived in Cameroon for several years in a rural village. Can this platform be implemented across borders?
Yes, so that is, like I said, that is what we want to. We've done the pilot testing in fewer facilities, but yes, because like I said, it is not is a digital solution, but it's not internet-based solution. So whether internet or no internet, in as much as these individuals have access to, they can make calls on their phone, right? And so they are good to go. Of course, like I said, mobile phone ownage in Nigeria is around 87%. So what it means is that this kind of programming can target 87% of the homes in Nigeria, so which is a good number. So it depends on the phone ownage in the location you're describing, as well as internet penetration, which is not even one of the criteria for assessing this. So once there's a good number of phone ownage, so the this app is good to go and can serve purpose.
Awesome, thank you. So our next question is from Elizabeth. If the person only has a phone, do they get to speak to a live person?
Okay, so that is the part that we are working on. Like if you go back to my slide, you see where I mentioned about NCC permission. So there were some licensing issues which we have already filled the forms, and so we're just waiting for those approvals. So that we'll be able to have a kind of a live phone in. We've secured the lines just for those approvals to come. So hopefully by the time we roll out, those features will be there, so people can phone in and reach out to like they want to talk to doctors for consultation, like telemedicine. Those features are already there, just the activation.
Perfect. And I actually was just curious about this. So I know you all sort of did some user testing. How did you recruit the users to sort of give you feedback and work with you as you were developing the solution?
Okay, maybe perhaps because I have a very good rapport with the Federal Ministry of Health, so I reach out to all the director of planning, research, and statistics, and I told them this is my ideation. These are the ideas I had, and I want to kind of test run on this. But before I even develop, I will like the real users to kind of make contributions and or even suggestions. So I reach out to the state, from the states to the facilities. So those facilities were able to give me number of the women that they are attending ANCs. I was able to get their contacts, contacted them, got their consent to say this is what I'm doing, but it's still on the testing phase. But if you can participate, so that it will even help us to kind of develop a robust system and number of participants while developing what literature have said, and those digital solutions or projects that have been done in Nigeria. I also kind of reach out to their sites, their previous beneficiaries, to kind of understand what are the gaps, what are the things they feel that would have been done better, and all that. So that also helped, in shaping how I was able to come up with this app.
Oh, perfect. And this is an interesting question that just came in the chat. Can the solution work for women with various types of disabilities?
I may not, this solution may not be for now. Like I said, there's room for improvement. So for vision impaired, um, um, for vision impaired, yes, because there is IVR, right? There is voice. So for hearing impaired, they cannot that also that can see in the hard vision, they can see, but other features for other types of disabilities uh is something that we can consider in the future. But we looked at, of course, when you're starting something new, you have to just start from somewhere, then build from as you're getting those feedback, you're making those input to ensure that it's all inclusive. But it's something that the system will consider.
Awesome. So we have 1 more minute left, so I'm going to just read one last question. So sometimes there are groups of people who don't agree about public health. When that leads to their different opinions expressed online, how does that affect the public and their reactions? This has happened in relation to immunization, for example, as someone raised in the chat.
No. Okay. So different people and how you address them. So how you would address vaccination issues in Nigeria, in northern Nigeria, is different from how you address it in the southern Nigeria. So in the northern Nigeria, is difficult is not difficult. Is difficult is that in the sense that if the leaders in the north said this is not good, everybody kind of want to go with that without questioning, right? So you not saying that people will not be able to question, but a large number of persons will agree to what the leaders, whether religious leaders or traditional leaders or any other leader in that region. So it's easy also now to work with these institutions to kind of get their buy-in, right? Once you get their buy-in and understand that this is for the common good, once they're able to stand with you, your work is done. Unlike in the South, everybody is more or less individual. So they take individual, decisions. Even within families, you could have different persons taking a different, understanding or direction to issues, public health issues. So it's a lot more harder in the South. But in the South, you also have more educated people in the South compared to the North. So it's also somewhat easy for you to also, interact at that level, to also get people to understand that, if we do this, we are all in for it. But this is the right information and this is the way to go. And this is also easy. So it depends on how you understand the context and apply those contexts to, really, drive that change that you really want to see at the community level.
Perfect. Thank you so much, Charles. This was a really great presentation. I definitely learned some new things about, the technology that you are developing and sort of norms in Nigeria. So thank you again. This was a really great presentation.
Thank you. Thank you.
Awesome.